There we are. Thanks everyone for joining us today. I'm Dr. Mike Bevilacqua. I'm a nephrologist over in Surrey and for Fraser Health. And for those of you who've been here before, thanks for coming back. If this is your first one, welcome. This is one of our webinar series. And today we're going to be talking about the various choices for a treatment with kidney failure. Before we get started, although we're meeting virtually, I think it's always good for us to reflect where it is that we come in this beautiful province that we share, and I think some attendees even from beyond. Myself, I come today from the traditional unceded territory of the Katzie, Semiahmoo, Kwantlen, and other Coast Salish peoples. And again, I think it's always good to reflect on the land that we all get to call home and attend this webinar from. As I mentioned, this is our one of our series of these webinars. Again, if this is your first time, thank you for coming. For your repeat attendance, that's fantastic. To orient you a little bit, all of these webinars, including the one that we do today, are going to be available on our website as well. We'll mention this again at the end of the talk, but in the meantime, if you have a moment to take a look, there's a few things here. If you direct yourself through to this screen here, you'll see that they are the recordings of previous sessions, a nice little calendar of events in terms of upcoming sessions, and there's a little button that if you click that says subscribe now, that basically you'll get an email invitation and an email notification every time we do one of these. We do them about quarterly, but you know the schedule sometimes does change a little bit, so that's a good function to know exactly when these happen. And again, for anything you see today that you might want to reflect on a little bit more, going back to the website will be the place to go if you want to look through it. So today, we're going to be talking about all of the various options that we have in terms of treatments for kidney failures. If you've attended some of our other talks, you may have seen that we have specific ones on each of these topics. We have a whole big session, for example, on transplant and peritoneal dialysis and hemodialysis and home hemodialysis. So this is kind of the 10,000-mile view of everything. And then if you like more information, you can go to each of those other specific sections as well. What we're trying to do here with these sessions is not to replace kind of one-on-one conversations that you'll have with your own kidney team, but rather the goal is to come in with a little bit of background, having heard all of this, and then that'll kind of inform you and be prepared for when you have those conversations with your own individual team. So this doesn't replace those one-on-one sessions, but it's meant to kind of put you in a good place and hear a little bit more so you can get the most out of those conversations. Now, as part of that, we do want this to be somewhat interactive. So as part of the housekeeping, and there's a question about this at the beginning, we very intentionally have muted your audio and turned off your video. And a lot of that is for privacy reasons, so that other people can't see and hear you. But we do want you to get questions in. And the way to do that is if you type in the Q&A box in your Zoom, that's how we'll get those questions. So there's two boxes. The Q&A is the one with the two little bubbles as opposed to the one. If you type the question in there, what we'll do is I'll kind of hold those until there's a break in the presentation, and then I'll make sure that we get those through. For a lot of the questions, what we'll be doing is to see, we'll answer them in kind of general terms. Anything that's very, very specific to your individual situation, I'll kind of suggest that you bring that back to your own kidney team to discuss. But these questions we'll try to phrase in a way that's a little bit more general and applicable, and then I'll bring that to the presenters in that way. So if you ask a question and you don't hear anything, that's fine. I'll kind of be holding them to points to the presentation, and we will get to it eventually. So please put your questions in that way, and I'll remind you as time goes on. Again, this one specifically, in addition to the recordings, it's worth mentioning that all of these various slides are available on our website in several different formats. So there's, the webinars are recorded up there, but also we have a self-directed multimedia presentation. That sounds pretty complicated, but it's kind of like a presentation that you can go forward and back at your own leisure and work your way through it. There's also just PowerPoint versions without the narration. There's multiple translations up there. So there's various different ways you can go through. And then the last couple of items is that when you signed up, you notice there's a little button that says, oh, let us know if you're okay with us letting your kidney team know you attended. And that's mainly so they can follow up with you afterwards. So if you did that, this is what'll occur. And lastly, at the end, there will be a feedback form. And again, I'll remind you at the end, but that's very appreciated to help us enhance these sessions as we go forward. Okay, so that's kind of the housekeeping stuff out of the way. Let's get into the actual presentation. So we're very, very lucky. We've got the team from Fraser Health today, the people that I get the pleasure of working with. We're going to walk us through this session. Sandra, one of our social workers, is going to take us through a bit of an overview. Then you'll hear from Roberta, who's specialized in transplant, and she'll take us through an overview of transplant. Katie with peritoneal dialysis, Neil with our facility-based dialysis, hemodialysis, and Merity with home hemodialysis. And then we'll go back to Sandra, where we'll talk about conservative management of kidney failure. That's our Fraser Health team that's going to be presenting. And then we're very, very fortunate. We have two excellent of our patient partners. We have Lloyd and Atticus who are going to share with us their lived experience going through these as well. And then we're all looking forward to that. So that's enough for me. And now at this point, we'll turn it over to Sandra and we'll get started with the actual content of the presentation.
Thank you. And I'm just going to bring up my PowerPoint here. Okay, so in this presentation, you're going to learn about the choices you have when your kidneys stop functioning. It's important that you understand your options so that you can make a choice that fits best for you. So let's get started. Kidneys are vital to our overall health and well-being. Healthy kidneys work to clean our blood by filtering out waste products. Kidney failure leads to serious health complications. There are a number of treatment options for people whose kidneys are failing, and it's important that you understand all your options so that you, supported by your kidney care team, can make the best choice for your situation. This chart shows the different levels of kidney functioning. You might already have some test results showing your GFR or the current level of your kidney function. If you know your GFR, you should be able to see where you fit on the chart. If you don't remember your GFR, you may be able to find it in your test results, or you can ask your healthcare provider. All about you. Most people who are learning about kidney replacement options are at the 15 to 29 level of GFR, shown by the orange box. What's important to you? When making a decision about your treatment options, it's best to think about what's important to you. There are a lot of things to consider, and here are just a few. Is it important for you to be in control of your time, or do you tend to do similar things every day, or does your daily schedule change a lot? Are you an independent person, or do you like to do things yourself, or do you prefer to have things done for you? Do you have a lot of activities in your day that are important to you, for example, such as working, volunteering, or family commitments? Would having a diet that restricts what you eat and drink be okay with you, or would you find that difficult? Are you an active person, or do you have a calmer stay-at-home lifestyle? These are just some of the questions to think about as you learn about the different options. They can help you decide which option might be a best fit for you. What would work best? We're going to look at the various treatment options. Most people with kidney failure will require more than one type of treatment over their lives, so it's good to know about all the options. And sometimes the option you think you would like changes once you learn about the others, or your healthcare team might suggest an option that could be a better fit for you and your situation. It's best to start by having an open mind. The treatment options available to people going through kidney failure are transplantation, peritoneal dialysis, hemodialysis, including home-based and clinic-based hemodialysis, and conservative care. This presentation will explain all the different options so that you have the information you need for thinking about which choice might be best for you. I'm going to introduce Roberta, who's going to talk about the process of transplant. Thank you.
Can you hear me now? And my screen is up?
Yeah, perfect.
Okay, thanks. Okay, so for kidney transplant, this is the treatment that is generally the #1 preferred treatment by people. There's a couple of reasons we really try and push for transplant. The first is typically people will live longer with a transplant than they will on dialysis. So that's one reason. But the most common reason people want to go for a transplant is that it gives you a better, more normal quality of life compared to that on dialysis. And that's because you don't have any dialysis to go to. You have a more normal diet and you have the freedom to come and go and travel as you please. So that's, like I said, the #1 reason people would prefer to do a transplant. When we're looking, so let me just go back for a minute. When we're looking at transplant, there are 3 hospitals here in BC that actually do the transplant surgery. One is Children's, which usually doesn't affect Fraser Health too much. And the other 2 are VGH and St. Paul's. Now, these are not 2 separate transplant programs. They are one transplant program under BC Transplant with 2 operating centers. So it's not an advantage to go to one hospital or the other. It's just a matter of which is more convenient for you, which one you're more comfortable with. So we do have the 2, St. Paul's and VGH for adults. When do people get referred for transplant? Well, that can vary. Typically, we want to see people referred when the GFR has dropped below 25 consistently. So not just one drop and then it comes back up, but consistently below 25, or there may be other indications that your doctor would see. Once they get referred, then we start with the assessment. Okay, so what is a transplant? Well, it's when we take a kidney from a healthy person, either that person was living or they're healthy enough after they've died and their relatives have consented to use those organs, and we surgically place that kidney in your body. Okay, it is not a cure, it is a different type of treatment. Why do I say that? Because you will need medication to protect that kidney and visits to the lab and to the doctor in the transplant clinic as long as you have that transplanted kidney in you. Okay? So what are the eligibility criteria that we use for transplant? Because just wanting a transplant doesn't mean we're going to do it. We need to make sure that we do it safely. So there are a number of tests that are involved. We need to make sure that your heart is strong enough for the operation, that you don't have any issues that make us worried about giving you the medications, like no active cancer, or there's been a certain waiting period if you've had cancer before we do that. Typically, when we're doing all of the investigations, it's on average, I would say about 6 months to do it. However, that is very dependent on people's willingness to do the appointments quickly. We can do it less than that, we can do it longer than that. So sometimes people have taken up to a year, but that's not typically from our side. It's because people don't want to rush through the process. So we're very flexible in terms of how fast we do this, but on average, we advise to plan about 6 months. Okay? When we're doing the operation, so once you've been approved, we've found a hospital, they've agreed to do the surgery, we've set the date. Typically, we do not remove your native kidneys. If you look at the picture on the bottom, that's the patient on the top is the donor, okay, because they've got 1 kidney left and 1 kidney is going to the picture on the bottom. So the picture on the bottom, you'll see the 2 kidneys at the top, those are the native kidneys. We don't routinely remove them. We did many years ago, but now they look at individuals and very rarely do we need to take those kidneys out. So you will end up with 2 kidneys that don't work, and then the new one usually goes in the front and it's placed in the lower abdomen, usually right or left side. That's the surgeon's preference. And that surgery takes about 4 hours to do. Okay. So the 2 types of transplants we have, I just mentioned briefly, we have the living donors and we have the deceased donors. I guess the most important thing to remember about that is the living donors come from the patient or the patient's family. You are responsible for locating and bringing a living donor. BC Transplant has waiting lists only for deceased donors. And when we talk to patients, when they get referred to us and their families, we give them a lot of suggestions and advice on how they might go about looking for those donors, what kind of language they can use and different strategies to help them. So it's not like we just tell you it's your responsibility that you go, we help guide you through that. For the living donors, well, one of the biggest advantages to having a living donor kidney is that we can do the transplant before you need dialysis. So if you're referred early enough that we've got that 6-month lead-in time or longer, we can get the patient ready, we can get the donor ready. And so when the time comes that we need to either do dialysis or transplant, we can go for transplant without needing to do dialysis. So that's one of the great benefits of a living donor kidney. The other benefit of a living donor kidney is that they typically tend to work better and last longer. Now, we can have really good, healthy, robust deceased donor kidneys that work very well and last a long time. But on average, we do see the living donor kidneys last a lot longer. We're telling people right now to expect about 18 years for that kidney. A lot of people are a little bit concerned about, well, will this be safe for my donor to give me a kidney? And the answer is absolutely yes. There is a very thorough and detailed evaluation that is undertaken by the donor teams. And there is a separate donor team at both hospitals, at VGH and St. Paul's, from the patient's team. And that donor team exists only for the safety and protection of the donor. So they only approve a donor if it's absolutely safe for them to do. Okay, so it's safe for the donors. They have to be very healthy. So when we're looking for donors, we're looking for the healthiest possible candidates. Okay, and we can accept donors from overseas. A lot of patients, a lot of people here in BC have relatives from outside the country. We can accept those. It takes a little bit longer because you're dealing with travel and having to do tests, overseas, and then mobilize donors here. But we can help you with that, and we can also help you with finances. All right, there's also financial assistance that can be available to help bring people over. So living donors can be preemptive, typically work better, typically last longer. Deceased donors. Now, deceased donors, you have to be on dialysis to get on that waiting list. All right. So once a person starts dialysis, that does not mean they are automatically on that list. All right. So once the person starts dialysis, they still have to be approved. So they can be approved before they start dialysis. They can be approved after they start dialysis. But either way, once they're approved, the first day of dialysis becomes the start date on the waiting list. How long can people expect to wait for a deceased donor kidney? Well, that depends on a number of factors. And the most common factor is the blood group, because we cannot predict which person is going to have an accident or whose family will agree to let us use their kidneys. So we've noticed that some of the blood groups, like blood group A, has a waiting list of around 2.5 years, whereas blood group B can be 5 years or longer. And it also depends on your age. Younger donors tend to wait less, older donors tend to wait a little bit older. And that's because we try to match up our deceased donors around similar ages. So we try to give younger deceased donors to younger patients, older deceased donors to older patients. Okay. We also have to take into account whether you have developed any antibodies. It may make it harder for us to match you with a donor. So this is why we can give you guidelines as to how long you might wait, but we cannot guarantee. And this is also why we may see some patients who have registered after you may get transplanted before you. That's because perhaps their blood group is different or they have less antibodies. But it is an option for people who don't have any living donors. Sorry. Okay, this is just a picture in the operating room. Picture of what a kidney looks like. Now, transplant benefits. I've already mentioned a couple of these. Number one is that with the living donors, they typically last longer and they typically have lower rates of rejection, particularly if this is a relative. They don't have to be relatives for living donors. They can be friends, family, or even strangers, as long as they're coming forward voluntarily and willingly. But when you have a family member, usually there's a better match. And so there's lower risk of rejection, need a little bit less medication. It allows for overall health. And like I said before, we can do this before you actually need dialysis. And then the deceased donor, well, we mentioned that about being on dialysis before you have that. Okay, now transplants take time. Okay, there is a waiting time for a transplant. And I did mention that about first needing to get approved and then waiting on the list. Once you complete the tests, then so you get referred here to Fraser Health. We will meet with you for about an hour, explain the process, what kind of things you need to do, what kind of things that, tests will be required, what you can expect. We'll give you the requisitions to start with the test, and then we will guide you through that process and keep in touch until those tests are done. Once those tests are done, we send the referral down to the transplanting teams. The transplanting team will see you. When they decide to see you will depend on how long they feel it is to the time of transplant. So if you are a person who has no donor and a long wait time expected because of your blood group, you might not be seen right away. If you have a donor, no matter what blood group you are, or if you're closer to the time of needing dialysis or transplant, you'll be seen earlier. So when we're talking about wait times, it's not just the wait times of you doing the test. We also have to fit you in with the transplant teams who, of course, are getting referrals from all over the province. So this is where some of our delays can come in. But again, we can move through the system very quickly, depending on how willing people are to complete the tests in a timely fashion. And that's pretty much, I guess, all I have to mention right now. So I'm going to sign off.
Oh, there's a few questions, so you're not getting off.
Oh, so stay on. Okay, I thought questions would be at the end, but I'm good for them now.
Yeah, we'll take a few now, and then as a reminder to everyone, please go ahead and get your questions in. There probably will be more at the end, and then we'll do kind of a rotating hot seat, but this is a good point where we'll put a couple of questions in for you. One, I'll just take, there was a question about candidacy, especially in the setting of things like malignancies or cancers and things like that. I'll say a couple of things. One, as I mentioned earlier, there's a whole webinar on our website that goes into a lot more detail about some of these topics. A lot of these, like this specific one, that is going to be a one-on-one decision. Roberta had mentioned that assessment by the provincial transplant center. This is exactly the type of thing that they will do. This is a one-on-one decision that will be made at the time. Okay, but there's a couple
to ask about cancer. Okay, so
right.
we follow the Canadian Society of Transplantation guidelines, and there are very clear guidelines for patients who've had cancer. So it will depend on the type of cancer, but even within the type of cancer, it'll depend on the degree to that cancer. Some cancers have 0 waiting time.
Yeah.
Some cancers have 2 years, some have 5 years. So it depends on the type and the extent of the cancer as to how long a person would wait. What's the next question?
So this is a good one, that if people are approaching, because you mentioned donors overseas, but let's say their donor is in BC, but in a smaller community. The question is, can a lot of the testing be done close to home, or how much do they actually have to come to Vancouver for?
Okay, so if there's a donor anywhere in Canada and the donor gets registered with our donor teams, remember there's a separate one at VGH, separate one at St. Paul's, we will do as much of the workup as we possibly can in that person's community. All right. Now, there may be some testing that if it's a really, really small community and we need a more extensive test, let's say we have an older donor that needs a stress test for their heart, maybe that's not available, they may have to travel for that. But most of the testing can actually be done in a person's community, and then they would just come here for the actual surgery. And remember, we do have something called the Living Organ Donor Reimbursement Program, which can help us with funding for patient costs. It provides up to $1,500 for travel, also covers funding for meals, accommodations, parking, things that would be donor expenses. So once the donor's ready to come down here, we can help out with some of that funding. If you have a donor overseas, once they come here, everything is free. Would we accept testing from overseas? Not usually. It would depend on where they are. So let's say, for example, they were in San Francisco. We could accept testing from San Francisco because we do consider their medical system on par with ours. But given the way the American healthcare system works, it would be very unlikely that the donor's test would be paid there. So it would be better for them to come here and have it done for free. If the person was in a developing country, say Egypt, for example, we would not consider that healthcare system on par with ours. In that case, we would not advise them to do any tests there. We would advise them to do all their tests here. But before you would mobilize that donor, we would first want to do some basic blood tests just to make sure that, you know, they didn't have hepatitis or HIV, that they were a compatible blood group. So for the testing overseas, we just do minimal, and then everything would be completed here. But if the donor's anywhere in Canada, even if it's a remote community, we would try and do it in their community as much as possible.
Perfect.
Another question?
Yeah, well, the next one, maybe the last one we'll do this section, is if people are trying to do this in advance of getting dialysis from a living donor, like you mentioned, is there kind of a rule of thumb of generally when that would happen? Or, you know, is it earlier the better, or do we wait?
No, it's not.
Point? You know, what's the rule of
Okay, so the official BC transplant guidelines say that the GFR should be 25 or less and consistently falling, and that the expected time of transplant is 1 to 2 years. So if you have a GFR, say 18 to 20, but it has been 18 to 20 for the last 4 years, that's not a reason to refer, because it could stay that way as well. I have many, many patients that have been referred many, many years ago, and they are still not progressing to transplant because they're still stable. And now they have to repeat all of that testing again. On the other hand, we don't want to have a referral when the person's GFR is 11 or 12, because now it's too I mean, well, we'll take a referral at any point, but now we're gonna probably have to plan for dialysis because I'm not sure we're gonna be able to get the testing done in time to avoid dialysis. My own personal experience, and I've been doing this for many years, typically a GFR 17 or 18 is almost the perfect number to be referred. It's far enough away that we've got enough time to do the workup, and anything we find we can deal with, but it's not too far away that the patient's gonna have to repeat everything in a couple of years.
Perfect. And actually, maybe the last question we'll get, there was several of them around age limits. Do we have an absolute age limit for
Age limit for
both
patients.
sides? Yeah.
So for patients, there is no upper age limit, okay? It's not how old you are, it's whether or not you are safe to transplant. And there are two factors we're looking at. Number one, is it safe to operate on you? Because the surgery is about 4 hours. Number two, is it safe to give you all that immunosuppression? Because those are very strong drugs. So typically, we approve people fairly routinely up to the age of 75. Over the age of 75, the transplant teams take a very close look at them and say, do we feel this person is safe or not? One of the things that I didn't mention with deceased donors is that about 30% of the deceased donors here in BC don't work right away. They do work after a couple of days, after a couple of weeks, but that's called delayed graft function. And what we found was that these donors that don't work right away, when we give them to people over the age of 75, it tends to be a little bit more of a negative outcome. So over 75, we don't automatically say no for transplant, but we may say, yes, we agree for transplant, and yes, we agree for deceased donor, but more often we'll say, yes, we agree for transplant, but only with a living donor because that makes the risk lower.
Perfect. Okay, great. There's a couple other questions, but I think they'll make more sense at the end in the context of everything else. Again, please keep getting your questions in if you have any. Thanks, Roberta. And now I forgot which one is next. Where are we off to next?
Me.
We are, there we go. We have Katie with peritoneal dialysis next.
Awesome. Roberta, do you mind just switching over your screen there? And then I'll throw up my slides. Thank you very much. Right. So, as Mike mentioned, my name is Katie and I work in the Abbotsford Peritoneal Dialysis Unit. And in this section, we're going to discuss what peritoneal dialysis is, some of the options that are available within peritoneal dialysis, benefits and drawbacks. So, let's see here. So what is peritoneal dialysis? Well, a tube is inserted surgically into your abdominal cavity, and then we put fluid through this tube, and it goes into the spaces between the organs that are already in your abdomen. While that fluid is sitting inside, or sometimes what we call dwelling, that's when the fluid, extra water and waste products from your blood are pulled through the peritoneal membrane and stay within inside of that dialysate. We then, after a few hours, drain it out of the cavity, and then we fill again with clean solution. And we repeat this process, and this is how we'll clean your body. And I know I just got my screen up and going, but I'm actually going to pause for a second because I want to show you what a catheter actually looks like. So, all right, Mike, you're going to have to jump in and let me know if you can't see me very well. But this is a catheter.
It's good.
I can hold up. That's good there. Okay. So on this end here, it's tough to see on this tiny camera, but there are little holes actually in the end of this catheter here, and it's like a soaker hose. So that's where the fluid is going to be going through and sitting into those spaces between your organs. Going a little bit further down here, you can see these two little fuzzy bits. And these pieces here are actually what your tissues grow into. So it anchors this catheter into your body, so it's never going to pull out, and it's going to keep any bacteria from coming in, fluid from coming out. On there is also a little white line, and what we use that for is if we ever had to check where that tube is placed, we can see that on an X-ray. The silver part here, this is a titanium connector. This is safe to go through an X-ray, MRI, CT scan, airport scanner, just like you would for an artificial hip. Connected to that is this last piece here. This is called a transfer set. And this is what connects up to the dialysis equipment. So this would go on either two systems I'm going to show you next. And on the end, to keep it completely sterile, this is called a mini cap. And on the inside of it has iodine. We put a new one of these ones on every time we do an exchange or changing of that fluid. So it sterilizes the end of your catheter and keeps you from getting an infection. I'm just going to switch back here. Okay. So, as I mentioned, peritoneal dialysis is a home-based dialysis. You can do this during the day or while you sleep, but you will need to have this catheter in your abdomen. So it is a permanent part. It is always attached to you. And there are two different types of peritoneal dialysis. There's continuous ambulatory peritoneal dialysis, which is our manual version using gravity. Usually it's done during the day. Most people will do it around their meal times, breakfast, lunch, dinner, and right before they go to bed. So usually 4 times a day. Everybody who starts on peritoneal dialysis does learn this system first because you can do it anywhere, especially important in the winter here where we've had snowstorms, ice, floods, any type of emergency where you could lose power, you still can do peritoneal dialysis. Some people find it actually fits their lives better to do it this way, especially for those who are long-haul truck drivers or people who maybe want to go traveling somewhere remote, camping maybe out in the backwoods where there's no generator, no electricity. It can go there too. Most people, though, do choose to switch over to continuous cycling peritoneal dialysis, or also called automated peritoneal dialysis. And this is where we use the machine. Usually it's done at night while you sleep. So that gives you your day free to go back to work, school. It gives you that control back of what you can do in the daytime. Dialysis is done at night. It usually takes about 20 to 30 minutes to set up the machine. And then it runs between 8 to 10 hours. And this is set depending on what your body is needing. Some people ask me if they're stuck in bed as soon as they connect up to the machine. And there's actually about 20 feet between you and the machine. So you can still be up and moving. You're not trapped in bed. You are able to pause and disconnect if you have to get up to the bathroom. So you're not stuck on this machine. You are able to disconnect yourself if that's a problem. I'm going to try one more time here. I'm going to pause the screen because I do have some equipment here in the room with me. So this one up on the pole behind me, this is that manual bag I was talking about. So it's 2 liters. A 2-liter volume is usually what we would use for people on peritoneal dialysis. And it is it's connected to a drain bag. So it's an all-in-one system. Everything is all done by gravity, usually using an IV pole. The other option was the machine. This one is the one that we've just started using here. It's quite small, easy to travel with. The main difference is the size of the bags, whereas the manual one is a single dose. That's a one-time exchange of draining out the old fluid and filling with new fluid. The machine can use up to 3 larger bags. And this bag is 5 liters in size. So this is more of a multi-dose bag. The machine is programmed to fill you with a certain amount, a certain volume of fluid. It's not going to put the full 5 liters in, but we need to give it enough fluid to work with over that course of the night. All right, and back to the presentation. There we go. Okay. So here's a picture actually of a lady setting up her cycler. We have 2 different ones. This is our older model, but we're mostly switching over now to using the newer model that's behind me. So as you might guess from these pictures and what I previously mentioned, one of the big benefits of PD is that you can travel. You do need to let the dialysis company know in advance where you're planning to travel to. Usually about a 3 to 4 month lead time is preferred because they'll want to know where you're going, connect with that site, and make sure that they can get the equipment all there for you. Usually they just need the address. What do you need? How long are you staying for? You will need to bring, if you're using the overnight machine, you do need to bring your own machine with you because it is programmed for what your body needs. I have lots of patients who go traveling on cruises, go to all-inclusive resorts, some snowbird patients who are actually going back down south for almost 6 months at a time. But you can also go traveling on weekend trips in the car. We have some people who are really into RVing and motorhomes, so this can be taken along with you. And actually we had a couple over the holidays who went traveling to different provinces to go see family members. So there's many benefits with PD, but the biggest ones are your increased independence and flexibility. You can adjust PD to your lifestyle. As I mentioned, you can do it just about anywhere and it's easy to travel with. Supplies are sent to you for free. So this includes not only the solutions, but an IV pole, a blood pressure cuff, a weight scale, dressing supplies, the machine. Everything you need to do PD is provided for you for free. And also, usually this PD comes with fewer restrictions on your diet. And if you're using the machine, the cycler, then most of your treatment is going to be done while you're sleeping and your day is free. PD protects your remaining kidney function more than hemodialysis, which we are going to talk about soon here. It's also gentle on your body because it works much like your natural kidney. And there are no needles used for PD, which some people find quite appealing. Some points to consider include having that catheter in your belly. Once we put it in, that's it, it's going to be in place. You are able to tuck this underneath your clothing. I have some people who will use a lanyard or tape it to their side, so it is discreet, but it is still in your belly. PD is done every day, so it is part of your everyday routine. Training is usually about a week in duration, but that does depend on you and your training nurse who you're working with. As I mentioned, the manual system is learned first, and usually the machine, the overnight cycler, is done at a different time. It does depend on your unit and where you're located in the province, though. Baths and hot tubs should be avoided by anybody on peritoneal dialysis because there is an increased risk of infection if the exit site where the tube comes out of your tummy goes under the surface of the water, but showers are okay. Another thing to consider is having space for supplies. So the picture down here in the bottom, this is about 1 month's worth of supplies that you would need to do PD at home. The company does bring the supplies to your home and they'll put it in the designated place that you're wanting. They'll rotate the stock and bring the old to the front, put the new stuff behind, but you do need to have somewhere where you can put it. I'm just going to play this really short video here. This is a fellow talking about his experience with PD.
And I got good advice from the doctors here at the hospital because they told me I really didn't know about it before. And they wanted me to go that way, and I'm glad I did. Most of the time while I'm doing it, I'm asleep. So it's really good that way. Everything's right there for you, and you can set up and do your run for the night, and you just do it. You know, I've just got it down. It's just part of the routine every day. You know, maybe I spend 15 minutes hooking up, and then in the morning another 15 minutes to shut it down. Oh, it's a great benefit. I've got lots of energy, and I get up at the same time every day and have a full day. I do it every night and for 8 hours, and everything seems to work pretty well.
Okay, so my last slide here, it's time to consider if PD feels like a right option for you. So if you started on PD, what would the biggest challenge be for you? What would be the best part or the biggest benefit of PD for you? What would worry you the most if you were doing PD? Is there anything more you would like to know? If so, write it down and then ask somebody from your kidney team or put it in the Q&A box there and we'll do our best to answer it. And that is me.
Perfect. And you're also not off the hook just yet. There's some really good questions and that was great. And all the multimedia things were fantastic. Okay, yeah, some really good questions here related to PD. So why don't we start with the first one that came through? You mentioned the fluid going in and out of the body. What do people report? Does that feel like? Is that an uncomfortable thing? You know, is it painful or uncomfortable to have that happen?
Great question. I get this one a lot. So it does change depending on your body's shape. If you're a larger person, usually you won't feel it as much. That being said, I explain it like when you're blowing up a balloon. The first time you blow up a balloon, it's quite stiff, it's firm, but the more you work with that membrane, the more times it's going to stretch and relax and you won't notice it as much. Definitely depends on where the catheter is placed, how someone's feeling, how full your bowels may be at that point in time. But once we've put in the catheter, it's had time to heal. Most people don't feel it at all. A lot of times it they don't even notice.
Perfect. Okay, and then there's some practical items around the catheter. So if
Mhm.
someone's had a lot of things like surgeries or things like that before, is it still possible for them to do the peritoneal dialysis?
For sure, this is something that the nephrologists look at quite seriously here. So surgeries does not mean that you can't have peritoneal dialysis. It would be something we'd want to consider in how we would be putting in the catheter, whether that would be in the peritoneal dialysis unit or if this would be in the operating room with a surgeon. Would depend what type of surgery. It does not rule you out from having PD, absolutely, but it would be something we'd want to talk about for sure.
Yeah, and there's a related question that came up about, can everybody do PD or things like that? And I'd say maybe I'll just take that one. There are a few situations where people can't, but it's much less than, for example, when we were talking about transplant. But again, this is the type of thing that you would have to discuss each individual case with your own kidney team, and they'll be able to tell you if it's right. But there are much fewer reasons people absolutely could not do this. Okay, a couple other practical ones. One person asked a question I was like, is it okay to do peritoneal dialysis if you have pets in the home?
Oh,
Is there
that's a good
anything we
one.
need to do about that?
Yes, please don't get rid of your pets. Let me start with that. If you ever read someone that says get rid of your pets, please don't. You can have pets, absolutely. The key is going to be having them away from you when you're doing your connecting and disconnecting, because that's when that tube that directly goes into your abdominal cavity is open to the rest of the environment, and we don't want anything getting in there. So pets are fine, but keep them away from when you're doing your exchange. I find dogs and usually that type, they're not so keen. Cats can get a little interested in the tubes that are moving, but please just keep them out of the room, and then once you're connected, it should be fine. I don't have much experience with any amphibians or reptiles, I'm sorry, but I know the fluffy ones.
That's right. That's why we both laugh. We get this question all the time. And cats are particularly the ones that they love tubes for some reason.
And
But
Bob.
yeah. Yeah, exactly. But yeah, like Katie said, that is not a reason you could not do this at all. We encourage people, obviously we want you to enjoy your life, and your pets are part of that. Okay, last two practical questions. So one, you mentioned on this briefly, but maybe just it came up specifically about if someone's using that machine at night and they have to use the washroom or something like that.
Absolutely, yeah. So we're really fortunate with this new one in particular that if you're having dialysis overnight and you realize, I gotta get up and use the bathroom, there actually will be a spot that comes up on here where you can push it and pause the machine so it won't move any fluid in or out of your belly. And it will already have taught you how to put on that little cap on the end and close off the line so you can safely disconnect from it. You put a sterile cap on the end that's on the machine here. You can pause it, I think, probably for about 15 minutes before it'll decide it wants to call you back and just check and make sure that you didn't go back to bed and forget about it, because it's easy to happen at 2 a.m. But you were easily able to disconnect and pause from this machine.
Perfect. And then the next practical question is the machine very loud for people who use it overnight?
It depends how sensitive a sleeper you are. Most people tell me it makes about as much noise as a fridge or a freezer. It's got a bit of a hum to it. There is some white noise from it. And then on its baseline functioning, it's really not that loud. Some people will put a towel underneath it. It'll muffle any sounds underneath it. That's totally fine. If you happen to roll over on the tube, something got kinked over, for sure it's going to beep and then tell you on the screen that you need to check the line, something's been kinked. But it's not very loud.
Perfect. And the last question, this is a good one. Actually, I don't think people asked this one before. That tube that we put in, does that need to get changed, or does it just stay in there?
That's a good one. The tube that we put into the abdominal cavity, that doesn't need to be changed. So when we put that in, that's permanent, and I use air quotes permanent because to take it out, we would just need to do surgery to remove it. Once we put the tube in and it's healed, we want it to be in for the entire time you're on peritoneal dialysis. The part that does change actually is the tiny little connection right here, the blue and white part. So up into that silver piece, that part we would change for you every 6 months, because it's what's going to get the wear and tear. It's what we're connecting up to the dialysis equipment. That's the part we want to get beat up, not the part that's in your belly we had to surgically put in. So there's two parts to it. One part yes, one part no.
Perfect. Okay, great. And so I think you're off the hook now. Katie, again, to everyone, great questions coming in. Keep doing so. Put them in the Q&A. Otherwise, it looks like next we're over to Neil.
Hello, good afternoon, everyone. I will just need to quickly set up here to make sure I'm showing the right page. Just bear with me, please. Dr. Mike, could you please confirm if you're able to see the test page?
It's on test page. Yeah, exactly. So you
Excellent.
passed the test. Good.
Thank you so much for the confirmation. Right. Hi again, everyone. My name is Neil. I'm a nurse at Surrey Hospital. My portion of this webinar is on clinic or hospital-based treatment. Hemodialysis, or simply hemo, is another form of dialysis that involves accessing the bloodstream with lines connected to a machine for the removal of waste and excess fluid. Just like any clinic appointment, once you're done with the treatment, and if everything is okay, you will be sent home. At the clinic, you will meet the dietitian, social worker, technicians, clerks, and nurses of different roles. A kidney doctor, just like Dr. Mike here, may see you, or he can be a call away. At our sites, one nurse would initiate and look after 3 or 4 patients on simultaneous treatments. Shown here is a common hemodialysis clinic where you will see beds, stretchers, recliner chairs. You'd see a variety of equipments and supplies, some of which are the hemodialysis machines. The machine setup in the picture is typically seen when a treatment is in progress. Here you'll see a screen monitor with information that the nurses will check to determine how you are progressing with the treatment. There are tubings that take a small portion of your blood for filtration through an artificial kidney, which we call a dialyzer. At every clinic appointment, you are weighed and assessed for new health issues or anything that requires attention. You may collaborate with your healthcare providers to determine what matters most to you. It could be that you might be considering a trip or need some guidance on how to go about the planning or preparation, among other things. Eventually, your hemodialysis is started and monitored. To pass the time, some patients would watch videos, read books, or do a crossword puzzle. A majority of patients, however, would find time to just chill out and relax. I recall working in a community clinic where a group of patients would play bingo and engage in group singing on special occasions, which apparently indicated that life goes on while receiving hemodialysis, or any form of dialysis, really. As mentioned, your bloodstream will be accessed to allow for the removal and return of blood. Nowadays, we commonly see at least 2 types, the fistula and the catheter. A fistula is made surgically by making a connection between an artery and a vein. Within a few weeks, the fistula would mature, enlarge, and thicken, and eventually used for accessing the bloodstream. On the other hand, a catheter found within the neck or groin is surgically inserted with local anesthesia and can be used right away. I won't be talking much about the vascular access, as there is an upcoming webinar on March the 10th, and more information are found on the BC Renal website. Going back to the fistula, the surgical connection between the artery and the vein has a good number of benefits. A fistula is the best choice as it has so much better compared to a catheter in terms of usability. The incidence of complications such as infection is fewer, therefore less incidence of hospitalizations. And it is safe to shower and go into the water with a fistula. A fistula may take up to a few months to mature, therefore it would be wise to plan for the creation before the expected time of use. That's with a fistula. The second commonly seen hemodialysis access is the central vein catheter. A catheter is usually used in emergency cases or when the vessels won't mature. Therefore, a Y-shaped tube joined together side by side is inserted into a large vein while the other portion sticks out of the skin. With a medical device sticking out, you may be susceptible to infection and other maintenance-related issues. That is why the fistula is the gold standard in terms of access choice. Let's go back to the moment when you arrived at the clinic. You are weighed, the nurse will check in with you to ensure that you're comfortable with the day's treatment plan. Pictured here is a patient with 2 needles. The first needle is for the outflow of blood from the access into the machine with a pump that circulates blood through the artificial kidney or dialyzer, which is a long and hollow device with a bundle of hair-thin fibers with very tiny holes that allow waste and excess water to pass through, after which the blood is delivered back into the body through the second needle. Hemodialysis at the clinic offers some benefits. All equipments are available, therefore you do not have to worry about storage. There are minimal instances for you to have your blood work done elsewhere, as the nurses have access to your bloodstream. Typically, each treatment is 3 times a week for 4 hours. Some clinics, however, may offer overnight treatment of about 7 to 8 hours, which is a more gentle and effective way of having dialysis while you're asleep. It's like flying in business class while someone is keeping an eye on you. The downside, as you dialyze with other patients, there is less flexibility in terms of schedule. It could be that you're doing a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday, or Sunday, either in the morning, afternoon, evening, or night. There could also be restrictions in terms of diet and travel. However, there are ways of addressing the issues. The video I'm about to show is an insight of a person's experience with clinic-based treatment.
The treatment itself is 4 hours, but generally I'm there 5 hours. When I get there, first thing, I have to weigh. And you write down how much you weigh. You have to take your temperature and write that down, so that when the nurse calls you in for your treatment, you can give her the little piece of paper, and that's like part of the work already. The advantages to in-center dialysis is that you can read, or you can watch television, you can sleep. You do have a little bit of freedom of what you want to do while you're there for the 4 hours. Tuesday, Thursday, and Saturday, I have dialysis. And Monday, Wednesday, and Friday, I like to go swimming. My general health is really pretty good. I certainly feel good on days that I swim, and I think it's because of the exercise. On the Tuesday, Thursday, Saturday, I feel okay, but after dialysis, I usually have a sleep.
Some people that are on dialysis are being pictured here. So this gentleman has a fistula, same with this guy. All right. Just to highlight some of the advantages and disadvantages of clinic-based hemodialysis. For the advantages, you have the option of having a day or nighttime treatment under close supervision, accessibility to equipments, routine blood works, and other services is possible. And you'll also have the opportunity to meet people for some support. However, you will have to travel to the site. You will be scheduled for your treatment. You might be with patients with a variety of health and other personal needs. At times, there could be operational and other concerns you might experience, especially if you're in a really busy hospital or clinic. That would be all from me. Thank you. Back now to Dr. Mike.
Perfect. Thanks, Neil. Very, very well done. I like your business class analogy there. Okay, there's a couple of quick questions here, which are good ones. And again, thanks everyone for getting those in. So one, there's a couple about the needles. Let's talk about that. One is, when you put the needle into that fistula, do needles just stay in there all the time, or does it get put in every time somebody comes for dialysis?
Wonderful question. Every time a patient comes into the clinic, we would have to look for the best spot. And typically, we would rotate the needling sites to ensure that we promote the longevity of the fistula, for instance. Yes, we do have to remove the needles after dialysis, and we would need to insert new ones when the patient comes back to for another treatment.
Yeah. And that's just because it would be an infection and a safety risk to leave them in. It's a common question.
That's
but
right,
Everyone goes in every time.
Mhm.
You mentioned you saw people talking about reading books and TV and stuff. So how still does someone need to be if there's a needle in their arm? Do they have to be completely immobile, or are they able to? Is there a little bit of moving around that can happen?
Wonderful question. We try to get our patients as active as possible when they're having dialysis. In fact, there are units with the exercise machine. It's a leg machine. It's like a cycling machine that they are being provided with. We would be starting somewhere in the east, in Abbotsford. This bike machine is being offered to the community dialysis patients. However, if the access site, for instance, is on the arms, particularly if it's the lower arm, then we would need to get our patients to ensure that they're not engaging in anything really, really rigorous or anything that would dislodge the needles. We use adhesives, adhesive tapes or tegaderms to ensure that none of the needles would come off during the treatment. However, we would need to be mindful. We remind our patients every now and then to ensure, particularly if they're new to the treatment, that they can move their hands or their wrist, because we wanted them to have good circulation. However, yanking their arms like this would not be recommended.
Yeah, and it sounds very tricky, but it's something definitely that people get used to.
That's right.
And we'll learn how to work with it. Okay, great. Great. So I think those are a lot of the questions. Some of you may realize I'm holding some, but I think it's because they'll make sense more at the end when we're if we're comparing all of the various treatment options. So with that, let's turn it now over to Meredy, who's going to talk about doing hemodialysis at home.
Hi, good afternoon, everyone. Thank you, Dr. Mike. My name is Meredy. I'm a nurse in the hemodialysis program in Fraser Health. So I'm going to just set up my presentation here. Give me a moment. You can see it now.
Yeah, if you just put it on the slideshow, so it's bigger.
Oops, sorry. I got it like, sorry about that.
Perfect.
Yeah. Yeah, as the name implies, home hemodialysis is a home-based independent hemodialysis. Our program provides training, follow-up, and support for patients who choose this option. An access is still needed, as discussed earlier by Neil, and then training will include how to use and care for this access. The training will also cover how to operate and troubleshoot the hemodialysis machine at home. So these are the two different machines that you could choose from with the guidance from a nephrologist and the home hemo team. The two machines are quite different. They differ in efficiency. The machine on your left of the screen is called the next stage. You need to do more dialysis on this machine, as it requires the patient to dialyze a minimum of 4 times a week for at least 5 hours at a time, and it uses significantly less water at about 60 liters per treatment. While the machine on your right is the AK machine, and it requires at least 3 times a week for at least 4 hours, and it can use about 400 liters of water per treatment. Both machines are as efficient as the machines used in center, the hospital, or the community dialysis unit. The next stage on your left is considered portable, although it still weighs about 100 pounds, so it's heavy, but it can be moved. We can provide rolling transport bags and supplies necessary for dialysis outside your home. BC Renal allows travel supply for up to 4 weeks in a year. The AK machine on your right is not portable. It can only be moved a few feet in each direction, but generally speaking, it stays where it is set up. Renovations are needed to be done for electrical and plumbing requirements of the machine. It looks like a water supply and some PVC pipes attached to the wall, and possibly some electrical modifications as well. The next stage machine does not require renovation, but sometimes a simple water line or drain modification might be needed. Any required renovations are paid for by BC Renal and will be removed if you choose to leave home hemo. It may seem like a lot to learn a complicated medical machine and may be challenging to take on the responsibility for your dialysis treatment. But our patients are well supported by a great team consisting of nurses, dietitian, a social worker, and nephrologist. A technical support for the machine by phone are provided by Baxter, available from 7 a.m. to 11 p.m., 7 days a week, including holidays. And for the next stage, available 24/7, including holidays. Training for either machine takes an average of 6 to 8 weeks, but every patient is different and will be given as much training time as they need to be comfortable and confident going home. It's okay to be home alone. Doing dialysis at home is a great option. This slide shows a patient at various stages of setting up the next stage cycler, which you will learn during training. You will also be provided with safety devices to ensure your risks are low. We will teach you how to troubleshoot and deal with emergencies. Doing dialysis at home requires a fair amount of space, like in PD. You need a designated area with a comfortable chair or bed with a space for the machine you will use for dialysis. You also need a space roughly around the size of a double closet for storing supplies of about 6 weeks at a time. That being said, if your space is small, our team can help you come up with solutions to hopefully make it work for you. So let's talk about the advantages of doing dialysis at home. It's often more gentle on the body because you have the opportunity to do longer, more frequent sessions. We encourage our patients to do more frequent dialysis and longer treatment hours to maximize the benefit of dialysis. You will start feeling better with more energy if you're able to do more dialysis. If you're doing more dialysis, the amount of medication you'll need may be reduced. Then potentially you will have fewer food and fluid restrictions. A specific team of nurse, a dietitian, and social worker will be assigned to you. We are a phone call away, available from 8 a.m. to 4 p.m. We can easily be in contact with your nephrologist as needed. You can make the treatment fit into your schedule. You can do the bare minimum of 12 hours a week or 20 per week or more. This flexibility can allow you to continue with your work, school, hobbies, or your favorite activities. Some patients choose to do dialysis while they sleep. They have about 7 to 8 hours of dialysis in each treatment, and their day is free. Reduced travel time is another great benefit. Traveling to the dialysis unit 3 times a week can be a big burden, especially for those who do not live close to the dialysis units. It can also be exhausting for patients who do not drive and are reliant on HandyDART, which is not always handy. Often, patients end up waiting for a long time for their bus and take a long way to be home. For those driving themselves to the hemodialysis unit, gas prices are really expensive nowadays. Plus, driving in the winter, when the weather is bad, or just dealing with everyday traffic can really be difficult and stressful. So dialyzing at home can save you a lot of your valuable time and save the frustration of travel. Although some independent center offer independent night hemodialysis where patients can do their own dialysis and they don't have to worry about the space they need for storage at home. Some reasons why people may not want to do home hemodialysis might include the storage space that is needed for the dialysis supply, the fear of isolation, the fear of being responsible for own medical care, the fact that training is a big time commitment upfront, training 6 to 8 weeks or more, coming to the HHD unit 3 to 4 times a week. We recognize that it may be difficult at first to commit to the training, but ultimately in the end, you will get your time and flexibility back. So going back to the benefit. Lastly, in Fraser Health, we have close to 40 patients currently doing home hemodialysis and the feedback is positive. Our patient prefers being at home than doing dialysis in center. Most of our patients stay with the program due to an improved quality of life and greater sense of flexibility and independence. I think that's all for my slide. Going back to Dr. Mike.
Great, thanks, Marty. Yeah, so a couple of questions have come through with this. So one is a couple of more straightforward ones. Is there any cost to doing all of this and having all this equipment at the home?
Yeah, that's a great question. So all equipments and renovations are paid for by BC Renal. So there's not going to be any cost for you.
Perfect. And then the same question has came up with PD. Is the machine very noisy? Because you mentioned some people doing it at nighttime.
I know. So the alarms in the machine can be a little bit noisy, but the volume can be adjusted. But it's more for safety, like, because with home hemodialysis or hemodialysis, there's actually a blood coming out of your body and going to the machine. So for safety, it needs to wake you up if accidentally it gets disconnected. So yeah, but the volume can be adjusted.
Perfect. Okay, and then there was a question about traveling. So if people were thinking of traveling, do they take the machine with them or do they just set up dialysis where they're going? What does that generally look like?
Okay, so as I have said earlier, we have 2 types. The next stage machine is like more so like a hybrid of the PD cycler and the hemodialysis machine. So the top part of that, you can travel, and then we BC Renal can give supplies for up to 4 weeks in a year. But the other one, the AK, is like it's set up and then it stays there. So we advise people, like if they're traveling, like to find a center where they could dialyze during their travel time.
Yeah, perfect. So in both situations, we still encourage people to travel, and it's just a matter of planning what that looks like.
Yes.
And then the last one, there's a comment that, compared to peritoneal dialysis, it sounds like a longer time. So, 6 to 8 weeks, that sounds a bit intensive. Maybe a comment of why that is longer than peritoneal dialysis and what's being covered in all of that time.
Yes, our training takes a little longer because there's a lot to learn. Like we have to teach you, first of all, like the machine, how to set it up. And then we also teach people like how to troubleshoot the machine. That amount of time is needed so that you will be safe when you go home. So it covers like a lot of teaching regarding like troubleshooting the machine, what to do in case of some emergencies, things like that. So that's why it's longer. And also we need to teach you how to use your access. And sometimes I know there might be a question that would come up here. What if I have a fistula? Can I do home hemodialysis? And the answer is yes. And it's a little bit different from the way they do it in the hospital. Like we start with the needle that they put in in the hospital, but then we create a buttonhole track. And then eventually when we send you home, you're going to be using a blunt needle to safely access your fistula.
Yeah, so there's a little bit more moving pieces that are involved My phrase I always tell patients when they're getting ready for this is that our job in that 6 to 8 weeks is basically to take someone off the street and turn them into a part-time dialysis nurse. So it's kind of like on the job training. So it's a little bit longer.
And also, just to mention, Dr. Mike, I would like to let them know too that part of the training, that's why it's a little bit longer too, is that you will do the training on how to set up the machine, and you will also have your dialysis while on training.
Yeah.
And then taking down the machine.
Yeah,
And then
good
the
point.
maintenance, yeah.
Definitely good point, Meredith.
Yeah.
Okay, and then the last one that came up was about, you mentioned if people do it over nighttime, does that mean they're kind of they have to sleep in a certain position, or how do we set that up for people?
Just like, when they go to the hospital laying on a bed, like when they do it in nighttime, usually when they're on a catheter, there's not much of a problem, but like if they have a fistula, like what I said, I showed in the picture earlier, like we have like some safety devices that would alert you when, there's blood, so it's gonna alarm. So, but yeah, you can still do it.
Yeah, and it's not that happens. I want to mention that's kind of the fail safe, but it's like a lot of other things. People ultimately, it seems awkward, but people train themselves, and people are able to sleep. But that's a very, it's an individual person to person thing.
Yeah, and over time they learn how to position themselves on the bed and then sleep comfortably while being safe.
Exactly.
And we have a lot of like home hemodialysis patients who do nighttime as well.
Exactly. Great. Thanks, Mary. So that sounds like all of the ones for you for now. And so now we're back over to Sandra.
Okay. I'm just gonna, hi, I'm Sandra. I'm a social worker at Abbotsford Kidney Care Clinic, and I'm just gonna pull up my slide here, and I'm gonna speak to the last topic of conservative care. So pull up my slide here. Okay. So this is the final piece of our presentation, and it's on conservative care. So conservative care means choosing not to do dialysis and not to have a kidney transplant. The goal of this option is to preserve the kidney function for as long as possible with diet and medication, but it doesn't include treatment. The focus is on what brings you quality of life rather than extending life. So if you choose conservative care, you'll still get the medical care, and your healthcare team will be with you the whole way through. Choosing not to pursue dialysis does not mean that other treatments aren't available to you. The focus of care for someone who chooses this option is to reduce the symptoms of their non-functioning kidneys and to make them feel as comfortable as possible. So I've just got a short little video here that I want to show you. Just a second here. Let's make sure I've got the sound on. Okay, here we go.
My kidneys went right down to 6%. They wanted to put me on dialysis, but that's one thing my family did know, and my doctor, that I said no dialysis. If I get that far gone, I'll take my chances. And at my age, I can't see any sense in it. And even the specialist, he agrees with me. He says, it might give you another year, or so, but it wouldn't be a quality of life that I would want.
Okay, so something to consider. So if you want to know a little bit more about conservative care, it's best to kind of talk to your kidney care team, and they can provide more information to you about it. And now I'm going to introduce Lloyd, who's going to speak on his experience with peritoneal dialysis.
Oh, and sorry, not to cut you off, but maybe just before Lloyd, before you start, there's one question, Sandra, and this one comes up often.
Okay.
So if people decide that they, you mentioned people deciding up front that they don't want dialysis, but what if somebody decides that they do want dialysis, but then after seeing how it goes, decides this is no longer something they want? Can they then go to conservative management of it?
Yes, definitely you can. And I mean, you would be talking with your nephrologist and your healthcare team along the way, and they would help guide you and kind of direct you and help you with that decision as well. But that's definitely an option for sure.
Yeah, and then, so perfect, thank you. And it's the same, actually, I want to mention for all of these, we're talking about making a choice, but nothing set in stone. And as I think actually, Sandra, you mentioned at the beginning that people often go through multiple treatments through their journey, and
Yeah.
that's very common. We do that all the time.
Yeah.
And yeah, so the last one I want to mention before we turn over to Lloyd. So you mentioned we manage symptoms. People are asking, is there specific ones that we look out for? And the specific question that always comes up is it a painful thing if somebody's kidneys are not functioning well?
So I don't believe it's painful, but they do get some symptoms like maybe shortness of breath, some cramping in their legs, some itchiness. So those would be the things that you would talk to your nephrologist about and your kidney care team, and they would help manage them with you.
Perfect, Sandra. Yeah, exactly. And I can confirm the same, because this is one of the big questions that people ask is, oh, would it be painful? And from the kidneys themselves, no, it's not something that creates pain. If there are other health problems, sometimes that contributes, but the kidneys themselves is not a painful thing. It's a very good question. Okay, sorry, I didn't want to interrupt, but I wanted to get those questions while it was still the iron's hot, so to speak. But yes, Lloyd, we would definitely love to hear your experience.
Well, I don't know how I put my picture up there, but okay. Well, my experience was that I was getting sick every morning. I had a heart attack in December, and then come June, I was getting sick every morning, and I am a type 2 diabetic, so my sugar levels had been high for about a month and a half, and then I just decided I couldn't wait for my internist any longer. I went to emergency, and the doctors there told me that it was a good thing I came in because I might have died, which was a bit of a shock to me because I'm fairly used to being reasonably healthy. So at that point, there was no choice for me. I had to, they basically, at the hospital, they inserted a catheter at in my groin area. This was a short-term catheter which would do the job but would have to be changed regularly unless I got a new catheter, which was for long-term use, which they eventually did get for me. And I think the wait time for installing the catheters was no more than about half an hour, and I found it not to be painful or stressful. The doctors are very good with what they do, so I was pretty confident they would be doing a good job. So I wasn't stressed out to begin with, and that always helps too when you're in a good frame of mind to attach this. So, but so after I'd been on the hemodialysis for about 8 months, 12 months, I decided that a nurse, Aman, told me that I should consider peritoneal, because if I wanted to have my time back, peritoneal would provide that time to me. And at my current state of hemodialysis, I was at a stage where I was going in Friday nights from 5:30 to 9:30, and that's usually where I would be doing my hobby, playing a concert with my orchestra. And so I didn't really appreciate the fact that my time wasn't my own time anymore. I managed to change to a morning cycle, which was much better for me, but I still wanted to sort of be in control, and peritoneal to me seemed to be the way to do that, because I would just set up at home. They would supply me with all the materials I need, the machine, the fluids, the bandages, the pads for bandages, and give me everything I needed to do the peritoneal by myself at home, plus provide me with the fluids and all the equipment that I needed, including the stand. When I was practicing gravity peritoneal, they gave me all the stuff I needed to do the gravity peritoneal at home too, which meant that I had to do it 4 times during the day. I think that's been discussed already. So I trained and was on gravity for about 3 months. And of course, they inserted the new catheter in my stomach, which I think you've already seen a demonstration of that too today. And so that was easily done. I didn't suffer any pain or stress for that. And once I had it in, then I would set my machine up. It'd take me about, at the beginning, it took me about 45 minutes to set the machine up. But now I can do it easily in 20, 25 minutes. And then it's ready for the following night. And I just hook up to the machine and I go to sleep. Or, you know, the machine does make a bit of noise, and sometimes it keeps me awake when I'm first going to sleep. But then after that, I don't wake up at night when it comes back on again. So basically during the night, I don't have any problem sleeping. If I do, if I am being bothered by the machine, I'll put an earplug in and that'll cancel out the noise that the machine makes. So just those little rubber twisting earplugs, you just put them in and they'll seal your air passages off from your ears and make it completely silent. You can hear the machine slightly in the background, but those earplugs work quite well if you don't want to hear the sound of the machine. So that was my way around that situation. I think the most important lesson I learned when I was doing peritoneal was cleanliness. I changed with assistance, I changed my bandage once a day, and that keeps everything really clean. And you don't want any bacteria or any alien objects getting into your catheter at all. So you make sure that you keep it clean, and you make sure you change your dressings once a day. That's easy enough to be done too. So it takes about 10 minutes to change the dressing, and then you're good for another 24 hours. So, and I thought that would be one of the things I would mention that was most important, is your cleanliness. I am considering now, after doing all this hemo and peritoneal dialysis, that I am thinking of transplant now, because to me that would give me the most control over my time and my situation. So right now I'm in the process of considering that option, and I'm starting to go through the testing, the EKGs and the blood tests and everything that I have to do to be included on the transplant list. So I'm sort of new at that right now, so I'm just getting going on it. So I haven't got much to say about that right now. I'm still learning. Anyways, that's basically what I have to say about my experience. So any questions from there, send them my way.
Yeah, thanks, Lloyd, and I'll see what comes in. That was a really good overview, especially talking about Lloyd's a very good example, as you saw, that he went through several different treatments and is now looking at another one, transplant, right? So, you know, sharing your experience through that road has been fantastic, Lloyd. Great, thank you.
Okay.
And yeah, and then as questions come up, please put them in. I'll direct them if appropriate. But maybe we'll also hear it now from Atticus, and then we can see you know, any common threads or questions that come up between the two. So Atticus, why don't we go over to you?
All right, thank you. Hello. So yeah, I'm currently on home hemodialysis. My kidney journey actually started several years ago. Originally, I was quite scared, and I didn't take any treatment options at first. I pretended that it would go away, and unfortunately it didn't. And I moved on to medical like prescription treatment for the hypertension that was causing my kidney issues. And that definitely worked for a while, but just about 2 years ago, I started to realize that my kidneys were declining to a point where I'd have to take additional measures. And I started looking at all of the different treatment options that have been talked about today. And what I ended up choosing was hemodialysis with a catheter, actually. I don't particularly like the needles, so I went with the catheter, and I will say I haven't had any complications with it at all. I've been very, very lucky. But yeah, I got the catheter inserted. I actually started hemodialysis the same day. It was quite convenient, actually, and I ended up doing hemodialysis with the catheter for about a year and a half. Just in community clinics. I enjoyed it, but similar to Lloyd, I found that it didn't really fit my schedule. I was doing, 3 days a week, 4 hours at a time, and I was finding that I was having to schedule everything around the hemodialysis. And in like late last year, I ended up discussing home hemodialysis with my team, and we decided to do the orientation. I actually spoke with Dr. Bevilacqua and decided that it was a good option. I did my training with my husband. Actually, it only took us 4 weeks. So we breezed through it. Found it super straightforward. My nurse, who was my trainer, who's actually just my nurse in general, super, super knowledgeable. Any questions that popped up, she was able to answer. So that was really helpful. And I've been doing dialysis at home now since just before Christmas. It was a Christmas present for myself. And I've been really enjoying it. It's been super, super convenient. As I believe Meredy mentioned, the gas prices were a major factor. My husband was having to, because I don't drive, my husband was having to drive me to and from dialysis. So that cost is eliminated. I've been able to spend more time with my husband, actually. We just hang out during my treatments. Yeah, it's been great. My whole team has actually been super knowledgeable and super helpful, in addition to just my nurse. Actually, my dietitian just called me this week to check in and see how I'm doing, and it was a nice surprise. We had a little conversation about just all the different things that I could be doing to make myself feel better. In addition to just doing my treatments, which actually I'm now doing 4 days a week at 5 hours. I'm actually feeling less washed out after treatments, which yeah, I would often have to take a nap after my hemodialysis treatment when I was doing it in community, but now I'm actually finding that I have to do my treatments in the morning because I have so much energy afterwards. Can run errands and do things, and yeah, I'm actually going to be meeting with my team next week, and like my whole team all at once, which is nice. And I might actually transition to doing my hemodialysis at night rather than in the day. So that's pretty exciting. And because I did see somebody ask about cats. My cat has no interest in my machine at all. She has not been a problem with any of the cables or the tubing or anything. So that's been fantastic. So yeah.
There you go. See, cats are possible. As we keep saying that. Do not get rid of your pets. Thanks, Abby. There's one question I might ask you that came up, because Lloyd had mentioned how long it takes him to set up the machine and everything. We touched on it, but it's always good to hear it firsthand. Like how there was a question of how much time does it take to actually, so not the treatment time, but the setup and all that kind of maintenance work. Does that take a lot of time?
I find about half an hour before, half an hour after. It doesn't really take that much. I could definitely cut that down, but I do find that the machine takes a little while to kind of warm up. So I'll turn the machine on, kind of hook everything up, go make myself a little bit of breakfast and a coffee, and then same kind of deal when I take it down. It kind of goes on its own pace, and you can kind of just leave it to do its own thing. So yeah, I usually say about a half hour before, a half hour after.
Yeah, perfect. And you're doing other things during that time, it sounds like. Yeah, great.
Exactly. Yeah.
Great. Thanks so much, Atticus. Fantastic. Okay, so there's now a couple of other questions. So maybe we'll go back and forward if everyone wants to kind of appear again with their cameras, because I'll kind of point to the person. We'll go back and forth. There are a couple questions that I'll direct around. There's actually two general threads that I've been kind of saving and I want to compare. So one, and maybe I'll just take this one, is around dietary restrictions. So this has come up in terms of every treatment, and we know it's always people's kind of one of their biggest questions. What I'd say is that that's, again, going to be individualized, and all of our treatment programs we talk about have dedicated dietitians who will kind of walk you through, for your exact situation, what you may or may not need to look at. But in general, what we find is that the restrictions kind of correspond to how good of a treatment you're getting, if you want to think of it that way. So when we think about transplant as being a functioning kidney, which is kind of the best type of clearances, it tends to be the lesser restrictions. People who are doing dialysis at home, and specifically doing more dialysis, like you just heard Atticus saying he feels better and can do more when he's doing more dialysis. One of the advantages there is also fewer diet restrictions, and then it kind of goes down the line. But for each of these treatment types, it's one of the things we'll be watching and monitoring with your tests, and then the dietitian will kind of walk you through what kind of restrictions. So I thought I would just do that as a big overall comparison, because for all of these, there's no free lunch, no pun intended, but we do see different degrees, and we have a whole team of people who walk you through that. Okay, and then so the next compare and contrast thing, because it got mentioned once during PD about things like swimming and things like that, but I'm actually going to ask it for each of them. So maybe Katie, I'll have you come back on for PD. You mentioned swimming, but what about things like bathing, and how do people manage that?
For sure. So for bathing, the preferred method would be showering, because you're not having water pressure putting any chance of bacteria down where the catheter is in your abdomen. There are actually special swimming dressings that people can get from their dialysis unit through the dialysis company, and we can teach you how to put those over top. I did have a patient who was a scuba diver, actually, and he didn't want to give that up. So we taught him how to use a one-piece ostomy bag, actually, that gave a good waterproof seal so he could continue scuba diving. It is possible, but we do need to make sure we go through the proper training of how to do it. Oceans are preferred. If you're going to be going in a large body of water, that's better. Small baths and hot tubs are not preferred, because there's a lot of bacteria that are in the water. So if there is a leak, if something does happen to get in the site, there's a very high chance of infection. So that's something to consider.
Yeah, thanks, Katie. That's perfect. And people often find that weird when we say that oceans are better, but it's because, remember, anything that can live in warm, fresh water can live in you, whereas anything that can live in the ocean generally can't. So yeah, perfect. Thank you. And then so Neil, how about maybe talk about for both a catheter and a fistula, in terms of what people might have to do for bathing precautions?
Thanks for that wonderful question, Dr. Mike, and to the patient, of course, who asked the question. With a fistula, there isn't restrictions at all in getting the access into the water. After the removal of the needles, eventually the skin opening would actually heal. And once it's healed, dressings or the bandage is gone. The bandage normally, or the Band-Aid would only stay for maybe 4 to 6 hours, depending on the healing process of the individual. When it comes off, the person with a fistula can actually have a regular shower, have a bath, can go for a swim. However, for somebody with a central venous catheter or with a neckline, the individual can actually go in a shower, but would need to take the necessary precautions. And it's so interesting that BC Renal actually has come up with a reminder. It's a step-by-step procedure on how to ensure that the exit site is not being soaked. Hence, we're preventing the onset of infection. So BC Renal has that website that has that access.
Perfect. Yeah, perfect. Thank you, Neil. And the difference there, as Neil said, with the fistula, there's really not much precaution, because where the issue comes is really just And it's the same with peritoneal dialysis. It's having a piece of plastic that goes from the outside in through the body, that's where you need to take the precaution around. So that's nature, right? Perfect. Okay, now this one has come up. This is a good question, and I think it probably is relating mostly to peritoneal dialysis and transplant. It's a good question that people don't often ask. So maybe I'll start, Katie, with peritoneal dialysis. In terms of the question is there any specific limitations or restrictions around things like sexual activity for somebody who's on peritoneal dialysis?
Absolutely. That is a great question. We do not get asked enough.
Yeah.
So no problems for sexual activity when you're on peritoneal dialysis. If you're feeling like you're full or a little bit bloated, you are able to drain out and you can be empty as long as the catheter is secured so it's not catching on anything and causing any pulling on the exit site where it is. Totally fine. We even have some patients that we tell you to pause the machine, disconnect maybe between your drain and your fill so that you're empty, but totally fine. No issues whatsoever.
Yeah, perfect. And Roberta, are there any restrictions that we put on people after they've had a transplant, since it sits there in the pelvis there?
Specifically sex, you mean?
Yeah, sexual activity.
Oh,
Yeah.
as long as the operation is completed and you're healed, because the operation is, sorry, if I stand up, you can see that we usually would place the kidney right about here.
Yeah.
Okay, it's an incision about that big right here. So as long as that incision is healed, it's just like somebody who maybe had a cesarean section for a baby. Once it's healed, there's no restrictions whatsoever.
Yeah, perfect. And I'm glad this one came up because people don't ask it often enough, but I know it's often in the back of people's minds. So it's an important thing to know. Okay, now we've got a few more here. Let me run through. Okay, there's a couple around peritoneal dialysis. So we talked about abdominal surgeries, but Katie, if people have had things like hernias, is that a barrier to them doing, or what do we have to do there?
So for hernias, if somebody has a hernia, this is again something that their kidney doctor would assess with them as well. Usually what would happen is we would get the hernia repaired and then we would put the peritoneal dialysis catheter in. Some people actually have that done at the same time if it's going to be done in the operating room. The reason being we don't want to have a weak spot in your abdominal wall there that could get bigger for putting fluid in and exerting any pressure. So no problem with hernias. If you've had an existing hernia repair, that's fine. We would want to know about it depending where it is. That may impact who puts in the tube and how we would go about it, but hernia is not a problem.
Perfect. And then lastly, since we chose since we talk about the renovations for the home hemodialysis and we're talking about machines, is there any renovations or anything that needs to be done with that peritoneal dialysis machine behind you?
I would say no. You really don't need to be making any renovations to the home. I have had some patients on their own choice who have decided to make a hole between their bathroom and their bedroom. We do not say you need to do that in any way, shape, or form. If you are further than 20 feet away from your bathroom and you want to use the overnight machine, we have drain bags that you can use to collect the fluid in the morning. Some people do it into a jerry can. Other people will run it into that drainage bag, but maybe it's already in their bathroom in the bathtub per se. It needs to drain down a shower, a toilet bowl, sink. So you really don't need to do any renovations for PD.
Yeah, perfect. Perfect. Okay. And then so Meredy, I'll go over to you for this next one. We're doing rapid fire. It's like you never know when you're gonna have to be called on here. It's like being in school when you're a child. So you had mentioned people kind of maybe training together along with family members, but what about the situation where if someone actually can't participate in it at all and they're going to be fully reliant on somebody else to do the treatment for them? Are we able to train, family members or loved ones without the person being involved in that, family members doing everything?
But the patients still need to come in for the.
Right.
Yeah, but yeah, like family members are very much welcome to train, like for the whole training or part of the training. Yeah, for support.
Yeah, exactly. And I think that's a good way of putting it. So it ranges the whole spectrum from, we have people who do it completely on their own. We have people who are completely, reliant on someone else, a loved one or a friend to help them do it. And then everything in between where it's, I think you heard Atticus, you were talking about you and your partner, you kind of both are doing it at the same time, and everything in between that spectrum. Okay. So let's go back to, so for transplant, I'll maybe reword this question, Roberta, because someone was, asking about compatibility of donors. So when people are looking for donors, do they need to explore, oh, is this person going to be compatible for me before they have them come forward, or what does that process?
No, the most important thing, now, we're talking living donors, I'm assuming. The most important thing in looking for a living donor is, number one, that they're willing and want to do it, and number two, that they're healthy. Everything else we can work with. If they're compatible with you, we look at the blood group. We make sure that you don't have any antibodies to that donor. But if you have antibodies to that donor or they're not compatible, we can exchange donors between families. We call that paired exchange. So the most important thing with the donor, they're healthy and they're willing.
That's a perfect sentence to summarize it, Roberta. And I've definitely seen it happen before, where people rule out in their mind somebody, and maybe they would have actually been a perfect, fit, right? So yeah, perfect way of putting it. Okay, and then the last question that's up there, that actually there's two more that I'll bring up. One that came up a couple times was around life expectancy with various treatments. I'll maybe just answer that briefly. In general, with all of these, what we're talking about, how long we expect someone to live, it usually has to do more with whatever else is going on with somebody rather than the treatment itself. We'll say on the whole, people with transplants will do better than people who are on dialysis, which is one of the reasons we say it's the preferred option. But there's so much individuality there, and it really has to do with whatever else is going on. Have you got heart problems or any other, health condition? And again, something I think to talk about with your individual team. And then the last one that I'll bring up, which is a good question, is worth repeating, is just someone had said, oh, if they had chosen to manage conservatively without dialysis treatments, and then they see their kidney function going down, but at the last minute they change their mind and decide they want to go down the route of doing dialysis, is that okay? And I could say, yeah, as is the case for all of these, nothing is ever written in stone. These are conversations, as you heard from our patients, they went through multiple different things through the course of their journey there, right? And so nothing's ever written in stone, and just bring it forward to your team. The more notice you give people, if you're thinking of changing your mind, the better, but at any time, we'll work with people and make it happen. Okay, so otherwise, oh, why is it not letting me share my thing here? I was going to put back up this slide, but why is that not working now? Because lastly, so one, if there are any other questions, I want to have people make sure they get a chance to get those in. Otherwise, here, I might have to do it this way then. I'm going to share up where we're going to put our a couple of links here. For some reason, my Zoom just stopped doing this. Nobody else is sharing, eh? That is so weird. Okay, well, sorry, and I'm not sure if Alexis, if you have it there, those couple of links, because my thing actually has just said that it's not allowing me to share. I think this is a Fraser Health computer thing, but regardless, I can go over a couple of items here.
Mine's actually saying the same thing too, Mike, so carry on.
So weird. Hey, that's a first, for however many years, that's a first that's come up. Okay, so at least it's not just me, there's something weird going on. But I just want to point people to a couple of things. We had a couple of links there. There's really two main places that we want people to check out. One is our BC Renal. So if you just put BC RENAL, if you Google that, it'll come up. A website where you'll see both all of these presentations that we talked about at the beginning, all the recordings of all these webinars, a place for you to sign up for if you want to be notified for future ones, and a whole bunch of other resources specific to any of these treatments we just talked about. There's a whole wealth of information up there. So please feel free to go through that. The other big collection of resources that I wanted to point people to is from the Kidney Foundation, and that's just kidney.ca. And there's a few great things that you'll see there. You'll see, again, a whole bunch of resources, videos, all kinds of things. And they also have what they call a peer support, a peer connect program, where if you're thinking of wanting to talk to someone who's gone through this themselves on a more one-on-one basis, they have a place where you can arrange that. So again, please feel free to go through there. Otherwise, after this, you'll get a little email that's prompting you to a little survey for feedback, which we'd love to hear if there's anything that we can do to help make this better. Then my last little plug is just like I said at the beginning, the whole goal of everything today was for you to get a chance to ask questions and hear a little bit more. Thank you all for your questions. They were fantastic. And then with all this information that you got, to go back to your kidney team and have these more detailed discussions about how this might relate to your individual situation. And then lastly, if there's no others, then I just want to mainly thank everybody who's presented here today. So all of our team that I'm very lucky to work with here in Fraser Health, thank you all. You did just a fantastic job. I want to thank Alexis and Janet for setting this all up behind the scenes and make all of this possible to do this in this webinar format. And then, mostly I do want to thank Lloyd and Atticus again for coming and sharing your personal stories with us. It's just always so powerful to hear, and I really appreciate you guys doing that. And otherwise, thank all of you for attending, and we look forward to seeing you hopefully at one of our future webinars as well.